Hello, Clinic Review family. It's Dr. Sharon with Clinic Reviews. Today we're going to be doing atrial dysrhythmias. We're going to be focusing on questions rather than looking at rhythms. You can get some rhythm questions, and I will eventually do some more of those, but this is going to be focusing on questions using words, and I want to make sure you can interpret rhythms using words, not just by looking at the rhythm. So let's go ahead and get started. Hello, my friends. Thank you for being a part of the Clinic Review family. You know that this channel is part of the greater Clinic Review organization. If you're interested in paying for any of the services that we offer, we have a 21+ hour NCLEX prep. It's online on demand, taught by the GOAT himself, Mark Klimek. It's phenomenal, in my opinion. It is the very best NCLEX review in the entire universe, in my opinion. So if you would like to meet me live over Zoom, you can sign up for our small group tutoring. I do the next gen tutoring, and you can also sign up for our streaming service where you can find all of the YouTube videos with no commercials, including all the videos that I've taken off YouTube over time. Everything is there that we've ever put on YouTube right from the beginning. So we're going to be doing atrial dysrhythmias today, and we're going to be focusing on atrial dysrhythmias using words. So if we're going to use words, then you have to understand that the P wave represents the sinus node. The P wave represents the sinus node. Now, if it's a sinus beat, the P wave is upright and rounded. If it's an atrial rhythm, you're still going to have a P wave, but the P wave is going to look different. So it's not going to be an upright, rounded P wave. It's just going to look different than that. So if we're doing atrial dysrhythmias today, pay attention to what it tells you about the P wave, and that's going to give you some clue about how to answer the question. A 68-year-old patient presents with palpitations and dizziness. Okay, that means they're symptomatic. Whatever it is, they come in with symptoms. On the monitor, you note an atrial rate of 350 beats per minute. Yikes. With a sawtooth pattern and a ventricular rate of 75 beats per minute. Which dysrhythmia is this? Atrial fibrillation, atrial flutter, sinus tachycardia, atrial tachycardia. So what are the key words here? We have an atrial rate of 350 beats per minute with a sawtooth pattern. So it is not an upright rounded P wave. It looks like a sawtooth, but the ventricular rate seems to be normal. So we have way more P waves than we do QRSs. So the ventricular rate is represented by the QRSs, and the P waves, there's like 350 for 75. So if we were to divide, I know I'm terrible with math, okay? So we're going to go 350 divided by 75. That means there's 4.5 P waves for every QRS. So there's 4.5, let's just say 5. Let's do 4. There's 4 sawtooth P waves for every QRS. So picture that in your mind. Normal QRS, 4 to 5 sawtooth P waves for every one of those QRSs. So we have a rapid atrial rate and a normal ventricular rate. So is that atrial fibrillation, atrial flutter, sinus tach, or atrial tachycardia? Well, we know it's not sinus tach because the P waves are sawtooth. And if it was a sinus rhythm, the P waves would be upright and rounded, and we'd have the same number of P waves for every QRS. You wouldn't have this differentiation. Atrial tachycardia, if it says tachycardia, that means the rate itself is fast. So atrial tachycardia, it means the heartbeat, the heart rate is very fast. So we'd have to have a higher rate than 75 ventricular rate. Okay, so the first word of the rhythm tells you where the electrical impulse is starting. The second word tells you if it's fast, slow, or normal. So the first word tells you where it's starting. The second tells you if it's fast, slow, or normal. So atrial tachycardia tells you the electrical impulse is starting in the atria, but the overall rate is fast. And here we have a 75 rate. Sinus tachycardia tells you it's starting in the sinus node, but the overall rate is fast. So that can't be it because our rate is 75. So it can't be either one of those. So we have atrial fibrillation and atrial flutter. So atrial fibrillation means, and I know, and the reason it doesn't tell you if it's fast or slow is because you could have it be fast. You could have atrial fibrillation with a normal ventricular rate. You could have atrial fibrillation with a rapid ventricular rate. You could have atrial flutter with a normal ventricular rate. You could have atrial flutter with a rapid ventricular rate. So it's atrial fibrillation or atrial flutter. The word fibrillation you have to think of as no pattern. Fibrillation means no pattern, which means if it's atrial fibrillation, that means there's no pattern to the P waves. Atrial flutter, you can think of the word sawtooth. Okay, sawtooth always goes with that. Now, so this is atrial flutter, but as a matter of fact, if we wanted to truly be accurate about how we would describe this, we would say this is atrial flutter with a 4-to-1 conduction ratio. Atrial flutter with a 4-to-1. There's 4 P waves to every 1 QRS, 4-to-1 conduction ratio. If when we have atrial fibrillation, this is not atrial fibrillation, but if we do have atrial fibrillation, we always say whether it's a normal ventricular response or a rapid ventricular response. So AFib with RVR is rapid ventricular response, because you can't really know unless we tell you specifically if it's going to be fast or slow. Which medication is most appropriate for rate control? Rate control has to do with the overall heart rate in a patient with atrial fibrillation and rapid ventricular response. So here we have AFib, so we have no pattern to the P waves, but we also have rapid ventricular rate. So the heart rate itself is going very fast. So what do we want to do? We want to slow down the rate, and if we can, convert them out of AFib. So we have 2 goals: slow down the rate and convert them out of AFib. Diltiazem, digoxin, lidocaine, adenosine. So adenosine will slow down the rate. Not sure if it'll get them out of AFib. It might. Adenosine might. So adenosine is an option. Lidocaine is more for ventricular dysrhythmias. Digoxin is going to slow down the rate, but it's not going to get them out of AFib. Diltiazem will slow down the rate and get them out of AFib. So we really have 2 options. We have diltiazem, which can slow rate and get them back into sinus, and we have adenosine, which can slow the rate and might get them back into sinus. But adenosine has a side effect that is more dangerous than diltiazem. Adenosine has a side effect of actually stopping the heart. The way it gets it back into sinus rhythm is by stopping the heart. And then the heart restarts again on its own. So I would rather, since I have the choice of giving diltiazem, which doesn't have that same side effect of stopping the heart, I'd rather give cardizem or diltiazem. That's what I would expect before I would give adenosine. Okay, that's just the expectation. Which patient teaching points are important for a patient discharged on diltiazem for rate control in atrial fibrillation? So even if we can't get them out of the AFib, it does control the rate, which is the ventricular rate, right? Okay, monitor blood pressure daily, rise slowly from lying to prevent dizziness, report heart rate less than 60, avoid grapefruit juice, check serum digoxin level weekly, take with food to reduce GI upset, expect occasional PVCs, increase fiber intake. So diltiazem is a calcium channel blocker, specifically blocks the calcium channels in the heart to slow rate. So it blocks the conduction through the AV nodes, which helps slow rate. It also, and the way it converts back into sinus rhythm is by blocking those same calcium channels in the heart. However, in this case, they're still an AFib, so we're just slowing rate. So it is a calcium channel blocker, so you should know it can affect blood pressure. So it could affect blood pressure, and then we also need to keep track of the rate, okay? So monitor blood pressure daily, yes, because it can lower blood pressure. Rise slowly from lying to prevent dizziness. Well, yeah, if it's a medication that can lower blood pressure, then it makes sense that you would rise slowly. Report heart rate of less than 60. Well, the purpose of the med is to control the rate, so we do expect it to bring rate down, but we don't want it to be less than 60. We know that's sort of the standard, right? Beta blockers shouldn't be less than 60. Digoxin should not be less than 60. Calcium channel blockers should not be less than 60. So that's sort of standard of care, so I'm going to go ahead and pick that one too. Avoid grapefruit juice. If you don't know that grapefruit juice disrupts so many medications, that what it does is it disrupts the attachment of the medication to the cell, to the receptors on the cell that it's supposed to attach to, and it does that for lots of medications. So really, anybody who's taking medications, we go, don't drink grapefruit juice. That's not your best option. Check serum dig level. Digoxin is not diltiazem. They are completely different meds. You don't have to check dig level when they're taking diltiazem. Take with food to reduce GI upset. So this is one you may go, well, I don't know. So what I say to myself is, do we tell people to take medications with food to reduce GI upset? And I say, well, yes, we tell them that. Is there any reason for me to think that a calcium channel blocker must be taken on an empty stomach? And I say, well, no. And I mean, I've given enough diltiazem in the hospital that I've never seen that as a note on the MAR. I've never considered it as a problem. Like, there's certain meds that I'm pretty sure should be given on an empty stomach just because I do it all the time. Like any of those meds that are ordered at 7 a.m., you know, those meds that it's sort of irritating, they're ordered at 7 a.m. because that's shift change. You're like, why is it ordered at 7 a.m.? It's because it's supposed to be taken on an empty stomach. So any of those meds that are ordered at 7 a.m. should be taken on an empty stomach. But you know, you and I both know diltiazem's always ordered at like 9, 10 o'clock. So it doesn't have to be taken on an empty stomach. So I say, well, sure, why not take it with food to reduce upset stomach? That just makes sense to me. Expect occasional PVCs. Okay, so I'm giving an antidysrhythmic. Right? Diltiazem is antidysrhythmic. That's why I'm giving it for a dysrhythmia. So would I say to them, well, I'm giving you this antidysrhythmic for this dysrhythmia, but expect another dysrhythmia. That just doesn't make sense, does it? That this antidysrhythmic is going to cause another dysrhythmia. That just doesn't make sense to me. So I'm not going to say that. Increase fiber intake. Well, does diltiazem increase their risk for constipation? Does it have any anticholinergic side effects? Because anticholinergic side effects, the meds like antidepressants all have anticholinergic side effects, so I tell them to increase fiber. So I say, is there any known reason why diltiazem would have anticholinergic side effects? And I say, not that I know of. Calcium channel blockers do not affect acetylcholine release. They affect the receptors in the heart, but they don't affect acetylcholine release. So I don't know of any reason to increase fiber intake. So the correct answers there are A, B, C, D, and F. And I hope I explained it adequately for you to understand that. A patient with chronic obstructive pulmonary disease develops multifocal atrial tachycardia. Which finding supports this diagnosis? PR interval greater than 0.20. Uniform P-wave morphology at an atrial rate of 180, P-waves inverted in lead 2, 3 or more P-wave morphologies. So I know this is a multifocal atrial tachycardia. So I do want the overall rate to be fast. I do expect the overall rate to be fast. But it's multifocal atrial, which means it has something to do with the P-waves, multifocal. So multifocal means coming from different locations. So remember I said the first word always represents where the electrical impulse is starting. So if it's a sinus rhythm, the electrical impulse is starting in the sinus node. If it's a ventricular rhythm, the electrical impulse is starting in the ventricles. If it's an atrial rhythm, the electrical impulse is starting in the atria. If it's a multifocal atrial rhythm, there's different places in the atria that are initiating this electrical rhythm. So I'm looking for something that says there's different places that's initiating this. PR interval greater than 0.20. That just tells me that, sorry, I have some in my eye. That just tells me that there's a delay between the atria and the ventricles. The PR interval represents the amount of time it takes to get from the atria to the ventricles. So if the interval is longer, there's a delay. But that's not what multifocal means. It doesn't mean delay. So I'm not going to pick A. Uniform, which means same, P-wave morphology. Morphology means where it's starting. So the same starting point for all the P-waves at an atrial rate of 180. Well, I like the atrial rate of 180, but I don't like the same starting point. Remember I told you it has to have multiple starting points. That doesn't mean you have 3 P-waves for every QRS. It means P-waves look different from each other, so you can tell they're being started from different places. P-waves inverted in lead 2. Well, I could have an inverted P-wave, but it's not specific. It's not like just one lead. This isn't saying in one lead. I don't know what that might mean, an inverted P-wave in lead 2, but it doesn't mean different starting points for the electrical impulse. That's not what it means. 3 or more P-wave morphologies. There we go. 3 or more places where the electrical impulse is starting, but there's a P-wave. So 3 or more places in the atria where this is starting. Again, it doesn't mean there's 3 P waves for every QRS. It means that as you look at let's say you get a minute-long rhythm strip, you'll find P waves that all look the same, and then you'll find another set of P waves that all look the same, and then you'll find a third set of P waves that look the same. They don't have to occur in a row. It could be like same P wave, same P wave, same P wave, different P wave, different P wave, third type of different P wave, right? And they kind of all go back and forth. And so you're like, there's different places that are controlling this rate. That's what it means by multifocal atrial tachycardia. Which clinical manifestations may occur with rapid atrial fibrillation? Rapid atrial fibrillation. So atrial fibrillation means no pattern. So there's no pattern to the P waves. So if we have, and this is probably not the best wording. It probably should say atrial fibrillation with rapid ventricular response. That's what it should say. So I apologize. I didn't do the good wording on this. Atrial fibrillation with a rapid ventricular response. Because you've got to understand, atrial fibrillation and atrial flutter, there are multiple P waves for every QRS. Multiple P waves for every QRS. With atrial fibrillation, there's no pattern to those P waves. So it's all just crazy stuff at the looking. With atrial flutter, it's a sawtooth pattern, but there's still multiple P waves for every QRS. So if you think that there's this rapid firing in the atria, brrr, like this, hopefully they don't all go through the AV node. Hopefully the AV node blocks a lot of those, right? So that it's the atria's firing, but the AV node's like, yeah, no, you're not getting through. In which case you're going to have a ventricular rate that's 60 to 100. But if you have a rapid ventricular response, you could have half of those P waves. Because remember, if you've got an atrial rhythm of say 350 and half of those are getting through, you've still got a rate of 125, your ventricles. So that's a rapid ventricular response. So which clinical manifestations may occur with atrial fibrillation with a rapid ventricular response? So what that usually means is it's clinically significant. It is symptomatic. AFib with RVR, that's symptomatic. So think about this. If you have a rapid ventricular response, it's really what this question is asking. What happens when you have tachycardia? Rapid tachycardia. So the heart rate, say, is 180. Like, what are the symptoms of that? One primary symptom is you don't have adequate filling time for the ventricles. Remember, the ventricles fill between contractions. The ventricles fill between contractions. So if you have a rapid rate, ventricular rate, you have less time to fill. So if you have less time to fill, you have less cardiac output. So what are the symptoms of decreased cardiac output? Palpitations, it feels like it's racing? Yes. Syncope, could you pass out because of decreased cardiac output? Well, if you don't have good cardiac output and perfusion of the brain, yes. Hypotension, well, if you have decreased cardiac output, does the pressure overall go down? Yes. Dyspnea, well, if you're not perfusing your tissues well enough to get oxygen, could you feel short of breath? Yes. Chest pain, if you have decreased cardiac output and you're not perfusing your coronary arteries, could you have chest pain? Yes. Jugular venous distension, well, if you have decreased cardiac output, it's not a volume problem. You have decreased cardiac output, and so where does the blood end up? Well, it ends up backing up, so you could have JVD, right? So yes. Bradycardia, that's a no. That's absolutely not, because it's rapid ventricular response, so bradycardia is not an option. Peripheral edema, and you might say to me, well, Dr. Sharon, if you can have JVD, you could have peripheral edema. Theoretically, but that's not usually how it works. Okay, because in order for it to get backed up enough to the periphery, you'd have to have it be backing up to your liver, like it'd be backing up a whole bunch of places. Like your blood pressure by that time would be so low before you end up with peripheral edema. So really, peripheral edema is a late symptom of heart failure. And really what we're saying is the ventricles are beating so fast, you have decreased filling time, you have decreased cardiac output. It's like an acute heart failure due to the tachycardia. There's not enough time to get to the peripheral edema stage. It takes a while to get to the peripheral edema stage. JVD, yes. Peripheral edema, no. Which electrolyte imbalance most predisposes a patient to atrial fibrillation? Hypermagnesemia, hypocalcemia, hypokalemia, or hypomagnesemia. All right. So this, I'm giving you a little heads up about one of the things we teach in clinic reviews. So I'm giving you something. We don't do this often, give away things for free that we sell, that we make people pay for. But I'm going to give you this little hint of one of the really awesome things we teach in clinic reviews. Heart rate always goes in the opposite direction of the electrolyte imbalance. Heart rate always goes in the opposite direction of the electrolyte imbalance. So if the potassium goes down, heart rate goes up. If potassium goes up, heart rate goes down. If the calcium goes down, heart rate goes up. If calcium goes up, heart rate goes down. If magnesium goes down, heart rate goes up. If magnesium goes up, heart rate goes down. That's why we never push electrolytes. You never push magnesium, IV push. You never do IV push calcium. You never do IV push potassium ever. Why? Because heart rate goes in the opposite direction. If you give it too fast, you're going to stop their heart. All right. So you might say, well, it could be hypocalcemia, hypokalemia, or hypomagnesemia. How am I supposed to choose between them? All right. So I would say unless the woman is pregnant and she's getting magnesium for preeclampsia or preterm labor, I would never really choose magnesium. That's just almost never the right answer. Okay, so I would just rule it out. Calcium, I would choose if it's nerve or skeletal muscle. So like if they're having tremors or hyporeflexia or hyperreflexia, that kind of thing, I'd go, well, calcium probably it, because the nerves and skeletal muscle is very sensitive to calcium. But the heart is incredibly sensitive to potassium. So I'm going to pick potassium because the heart is so sensitive to it. And remember, atrial fibrillation is an up heart rate, and heart rate goes in the opposite direction of the electrolyte imbalance. So I'm choosing hypokalemia. A patient with atrial flutter, remember that's that sawtooth pattern, multiple P waves for every QRS, develops hypotension, chest pain, and altered mental status. What is the priority intervention? So some people can sort of be living in atrial flutter. The risk is they're going to throw a clot. So we give them anticoagulants to prevent that from happening, but they can sort of live in that. So at what point are we concerned about it? Well, we're concerned about it when they're symptomatic. So atrial flutter, if they become hypotensive, that means cardiac output has gone down. Chest pain means cardiac output has gone down. Altered mental status means cardiac output has gone down. So they're in atrial flutter and maybe they've been okay, but now all of a sudden it's affecting cardiac output. So we've got to get them out of we've got to get them out of a flutter. That's what we've got to do as quickly as possible, because they are now having an acute heart failure. So administer IV metoprolol. That does slow heart rate. Prepare for synchronized cardioversion. Synchronized cardioversion is sending an electrical impulse through the entire heart all at once. And hopefully, when it comes back online, the sinus node takes over. Give sublingual nitroglycerin. Well, that's treating the symptom of chest pain, not treating the cause, which is atrial flutter. Obtain a 12-lead ECG. You could do that. I mean, that's fine. But they're in an acute heart failure. So the correct answer, the quickest way to get them out of this rhythm is synchronized cardioversion. Which nursing interventions are appropriate for a patient after synchronized cardioversion? Okay, so we just electrocuted their heart, which stopped their heart temporarily, and hopefully the sinus node took over. But we did just put the paddles on them and send an electrical impulse through their heart. So what do we want to do after we do that? Monitor the ECG. Well, that seems like a good idea. I know I should be reading through all the answers first. Let me go ahead and do that. Monitor the ECG, assess skin for burns, check cardiac biomarkers, maintain patent IV access, administer anticoagulants, apply ice packs to the chest, evaluate neurologic status, measure electrolytes. Okay, so we've just cardioverted, hopefully, back into sinus rhythm. We did use electrical paddles on the chest, and we need to make sure they're doing okay. All right. Monitor ECG, absolutely, right? We need to keep an eye on that. Assess skin for burns. I hope it didn't happen, but I'm going to check and see if it did. It could have happened. Check cardiac biomarkers. Do you know what cardiac biomarkers are? Biomarkers are cardiac enzymes like troponin, right? We want to see if they were in atrial flutter, did they end up having any cardiac damage from this? So let's go ahead and look and see if there was any cardiac damage. So let's assess cardiac biomarkers, maintain patent IV access. That's a good idea. That's just common sense. Yeah, let's have an IV in case we need to give them anything more. Administer anticoagulants. I told you atrial flutter can cause clots because you have turbulent blood flow. We just we just synchronized them back out of that. So if they had a clot and then we put them back into sinus rhythm, where's that clot going to go? Well, it's now going to go out into the body. So let's administer some anticoagulants to prevent that from happening. Apply ice packs to the chest. Why would we do that? What's the purpose of that? Well, if they have any burns, well, we don't know if they have any burns. And even if they did have burns, I would not do ice packs. I would do other things. I don't know of any reason to give ice packs to the chest. Like, that doesn't help anything. Like, it sounds good if you don't know what you're doing. Like if you were just a lay person who'd never studied any of these things, you might go, oh, okay. But no, y'all, no. Don't do that. That just doesn't make any sense. Evaluate neurologic status. Well, yeah, we just cardioverted them, synchronized them, cardioverted them, cardioversion. So yeah, let's just make sure they're doing okay, alert and oriented. Measure electrolytes. Well, they were in atrial flutter. Could that be caused by hypokalemia? Yes. Could it be caused by another electrolyte imbalance? Yes. So let's check it and see. All right? Okay. There was a lot of common sense, actually, with this particular one. There was also a lot of need to understand vocabulary with this one and to understand meds. So this was not easy. So if you did really well on it, I would say you've got a very good understanding, cardiac understanding. That's great. Focus on other things. If you did really well on this, you're good with a lot of this. Like, focus on fundamentals, make sure you got that down, and so forth. So if you struggled with this, maybe go back and review your cardiac a little bit. Watch some of my other cardiac rhythm videos. Those probably would help you. So that would be my recommendation. So thank you for being a part of the Clinic Review family. Good luck on your NCLEX.